In patients with absolutely no underlying cardiopulmonary disease, the induction of general anesthesia causes dependent atelectasis 90% of the time. These CT scans illustrate the collapse. On the right, after anesthesia, up to 25% of initially healthy lung tissue becomes completely dense, reducing the cross-sectional area. Physicians frequently treat this intraoperative collapse as a temporary nuisance of gas exchange, reversible by adjusting ventilator settings. But treating this clinical condition as a simple, reversible loss of volume ignores the hidden pathology occurring at the cellular level. The collapse is a severe biomechanical failure of force vectors, initiating a localized biological crisis. Understanding the collapse requires viewing the lung as an active zone of structural and molecular injury. Lung expansion requires an equilibrium of forces. Outward expansion relies on internal alveolar pressure, PI, and tethering stress, FO, pulling airways open. Opposing this are collapsing forces, external pleural pressure, inward tissue tethering, FI, and radially inward surface tension, marked by green arrows. The Young-Laplace equation dictates pressure equals surface tension divided by radius. As an airway shrinks, collapsing pressure spikes exponentially. Pulmonary surfactant is the mandatory stabilizer, reducing surface tension to prevent collapsing pressure from overwhelming the shrinking airway. Alveolar equilibrium is inherently precarious. Maintaining a patent airway requires a constant high-stakes balance against the lung's own geometry. Inducing general anesthesia in a supine patient introduces specific variables that dismantle this physical equilibrium. An awake patient's diaphragm maintains tension, shielding lungs from abdominal weight. Paralysis removes this shield. The diaphragm shifts upward, transferring abdominal pressure into dependent lung fields. Pleural pressure flips positive, overpowering alveolar opening pressures, creating a dense wedge of atelectasis at the base. High-inspired oxygen accelerates collapse. In this schematic, oxygen's high blood solubility causes rapid absorption into capillaries, marked by blue arrows. In dependent areas, gas flowing into blood vastly exceeds fresh air inflow, creating a vacuum that physically shrinks the alveolus. The combined physical pressure crushing upward from the abdomen and the rapid internal vacuuming of gas ensure the mechanical buckling of dependent lung tissue. The body immediately reacts to this local hypoxia through hypoxic pulmonary vasoconstriction, a reflex that constricts local vessels to divert blood away from the collapsed oxygen poor zone. However, volatile anesthetics administered above 1 minimum alveolar concentration blunt this reflex. Blood continues flowing through the collapsed tissue, causing systemic hypoxemia. Within the collapsed tissue, immobility takes a physical toll. Lacking cyclic stretch, the actin cytoskeleton inside epithelial cells begins to disorganize and completely degrade. This diagram details structural dysfunction. Immobility shuts down YAP signaling, impairing epithelial repair. Injured cells secrete chemokines, recruiting aggressive macrophages and neutrophils. The endothelial glycocalyx fractures, leaking plasma proteins that flood the airspace, deactivating surfactant, and forming a fibrin web that seals the alveolus shut. Within hours, a simple mechanical deflation evolves into a highly localized, active inflammatory disease state. Treating this inflamed, collapsed architecture with standard mechanical ventilation introduces a paradox. Pushing tidal volumes into this heterogeneous tissue inflicts severe microtrauma. This pulmonary pressure volume curve illustrates lung hysteresis. Because of surface tension and fluid buildup in the collapsed units, the initial compliance is very low. The pressure required to force these closed units open is significantly higher than the pressure required to keep them open. Forcing units open causes interfacial propagation. As air bubbles push through collapsed airways, longitudinal pressure gradients physically fracture epithelial membranes. Second, stress concentration occurs. Non-expanding collapsed alveoli act as force multipliers, ripping the extracellular matrix of adjacent open tissue. Finally, remote overdistension occurs. Because the dependent lung remains collapsed, the incoming tidal volume is redistributed upward. The air has nowhere to go but into the healthy, non-dependent lung tissue, forcing it into severe hyperinflation and strain. Mechanical ventilation applied to an atelectatic lung does not gracefully reinflate it. It shears, tears, and overdistends the tissue at a microscopic level. Perioperative atelectasis begins as a highly predictable physical vector failure, triggered by neuromuscular paralysis and altered chest wall mechanics. This physical buckling dictates a harsh biological reality, a localized environment defined by immune dysfunction, structural barrier failure, and surfactant degradation. When we apply specific mechanical interventions like PEEP, we aren't just improving oxygen numbers, we are preventing the specific biomechanical triggers for this disease. Proper pressure keeps the lung open, preserving the cyclic stretch required for YAP signaling and preventing the interfacial propagation that fractures cell membranes. Without these maneuvers, applying standard ventilation over a disrupted, heterogeneous architecture guarantees microscopic trauma through shear stress and stress concentration. Therefore, optimal ventilator management must be viewed as a biological disease modifier. It is the critical intervention required to stop a transient physical collapse from translating into permanent structural lung injury.
At CB Institute, where knowledge blooms, we prepare the future of nursing.